after a test like that, as opposed to like after like a farm test or something. But congratulations, yay for Pat, that's done. Another class box checked, moving forward. You had a decent weekend. I'm hoping that you guys like built a buffer to where like the third path test, you got a little bit of U time. If not, sorry. You're all working on papers this semester too, right? The rough drafts. How many haven't even like started writing the rough draft yet? Yeah, there we go. Yes. Yes. I love the honesty in this class. This is one thing I can appreciate. You guys are always like cold and honest. Like in that aspect where you're like, this is how it is. Like I mean, I'm not cold-hearted. That's me, right? Direct. Thank you. Words. Words are important. It's Monday, but yeah, no, I love that. That's good. Just know that your rough draft is meant to be rough, right? It's okay. I told my counselees this already. Like it's gonna be rough. It's okay. That's why you do it this semester, so that way next semester you just gotta tweak things. But all right, any questions from last time? Not that I expect you guys actually looked at any of my stuff with Mr. Weber's test today. Yeah, okay. All right, well, keep them coming. You guys have a good question on the breaks and through Canvas and stuff, so please keep that going. We are going to jump into describing fractures now. We've been talking about them, finding them, right? You guys are starting to get good at finding these things at least a little bit, right? You need to know, right now, have you learned exactly what to call it stuff yet? Just that incomplete, right? We talked about that green state, that torus, some of those incomplete ones. But now we're going to dive into how do you describe these? If I talk to someone on the phone, what do I say to them to paint that picture, right? I'm talking to you because maybe you're the ortho person, or maybe I'm at a rural family practice clinic and it's something that needs to go to surgery and I don't have a surgical place, so I'm sending them to the ER because the hospital has surgery, so we're going to call and give that warm handoff, right? So how do we describe these? So the gaining provider knows exactly what you're talking about and can understand what that patient's going to need kind of going forward. And we will get into Salter-Harris on this one too. So yay. So here's not going to cover the basics. Obviously, you can't do things without the basics. Counting fragments. I got news for you. It just needs to know if it's 2 pieces or more than 2 pieces. Because anything more than 2 pieces is the same thing. So don't get hung up on actually counting them. As long as you can make it to 2, you're going to be all right. All right? Make it easy. I know. Sorry for you. Practice that. What's the direction of the line, right? The direction of the fracture, which way does it go? That'll help us kind of know what to call it. The relationship of one fragment to another. This goes back very similar to the dislocations. When we're talking about how do we name things if the bones are moved, right? Joints get dislocated because we have 2 things in a joint that move. It dislocates. That's not where it's supposed to be. When we're talking about fragments, that's called displacement. And we're going to talk about that today a little bit. Don't get those words confused. Dislocation and displacement look very similar. So when we're taking a test, you get excited because we know the answer. We see the first word with DIS and we click it and move on and didn't realize we clicked displacement, we might dislocate it or vice versa. And then we lost 2 points on something that we knew, right? So take your time and read it. I don't know about you, when I sat there, I could handle not knowing a question and getting it wrong. I was like, I was between 2 and I was like, I got it wrong. Okay, fine. But boy, did I hate it when I knew the answer and I just clicked the wrong one because I didn't read it all the way through. Don't do that. All right? So we're talking about relation to the fracture of the atmosphere. Salter-Harris, we'll spend a little bit of time on this, okay? Because this is really important. And then we already kind of looked at healing fractures. We'll look at it a little bit more, talk more about what happens when a fracture heals but not completely together, right? There are things that we use, words we use to call those things. Okay, so the first thing, what bone is it? Gotta know my anatomy. We no longer use things like leg in this course, right? Or arm, or lower leg, or upper leg, or hip, or whatever. We use the bone, femur, ulna, radius, humerus, because you got to keep in mind, you're talking to somebody on the phone who doesn't have the picture in front of them. They don't have the patient yet. So you're describing the bone that's actually broken, okay? Using big boy and big girl words. It's not a collarbone anymore. It's a clavicle. Okay? So like understanding those words. You can use a both bone for the forearm. So I say, hey, use radius or ulna, that's fine. If both bones are broken, you can say, I have a right both bone forearm fracture. Right, because there are only two bones in the forearm. We're not confused on what those are. Where is it fractured? Proximal, mid-shaft, or distal. That is anatomic position. Right? Depending which way the x-ray is presented to you, we do it based off an anatomical position. So if I'm doing the radius and the ulna, regardless if the x-ray looks like this or it looks like this is the distal area of the radius and the ulna. Right? So just a normal anatomic position. Lots of different classification systems, and we're going to talk about the anatomy a little bit. So, a simple fracture is two or fewer fragments or pieces. All right? Two or fewer pieces. That's a simple fracture. It's typically one fracture that creates two pieces of bone. So we've seen this x-ray before, right? We have piece 1 and piece 2. Piece 1 and piece 2. So this would be a simple, we'll talk about the area in a second, mid-shaft. Okay, which bone is this? Radial fracture. That is what I would call that. Simple mid-shaft radial fracture. I'm not going to talk about the direction of the fracture yet because we haven't quite gotten into there. But this is a simple fracture. If it's two pieces or less. How can I have less than two pieces in a fracture? It's incomplete. Good, yes. It's incomplete. It's pediatric, right? Those green sticks, those toruses, those are one-piece fracture. The bone is still one piece. It just has a fracture in it, so that's incomplete. So two or less is simple. Anything more than two, so I see I said count to two. One, two, many. I don't care how many there are, right? One, two, many. There's more than two, okay? Couple of different ways we can use this. So this particular one, a segmental fracture is okay. Butterfly fragment's okay. I'll explain what a butterfly fragment is, but I don't want you guys to get too hung up on it. That's going to be more ortho would like to know that. But if a butterfly fragment is basically like a kind of little triangle piece, we'll see another piece of it later on. But really, it's segmental, and the big word too is comminuted. Okay? Segmental fracture is a comminuted fracture. Comminuted means more than two pieces. 3, 20. Don't care. Comminuted. Segmental, butterfly. For this course, you're all going to be the same thing. Okay? Which means you won't have 3 different answers, one with segmental, one with butterfly, and one with comminuted. Right? Both of the segmental and the butterfly are a type of comminuted fracture. That is the big overarching term, is the comminuted fracture. And that's anything more than 2 pieces. Yes, ma'am?
Would it be for the entire area? Because obviously there's 2 different bones. One
Yes.
looks like a simple and the other one is.
Good. We haven't gotten there yet, but we'll do it now. That's fine. That's a good question. So the question is it the whole area? Because what she's seeing here is a comminuted fracture on which bone? Tibia. And then which other bone is fractured? That is important. Fibula, right? So you are correct. So it is based off of the bone, right? So what I would have here is a comminuted tibial fracture with a simple fibula fracture, because the fibula is only 2 pieces. So it's not whole body, right? And that's why we get away from leg, arm, lower leg, right? Because if I'm describing the lower leg, well, we're taking this whole thing into account. But when I describe it by bone, I have 2 different descriptions, right? The comminuted tibial fracture and the simple fibula fracture. Good question. So here's another picture of a comminuted or segmental, right? Let's count the pieces together. I got 1, I got 2, I got 3, now I got 4, 5, and there might even be a 6 here, I can't tell. So for this side of the room, 1, 2, 3, my big pieces, 4, 5, maybe a 6, but I don't care, because once I get to 3, it's comminuted. I mean, the patient cares and I care for surgery, but for describing it, I don't care. Everybody see that? What bone is that? Is that a right or a left femur?
Right.
Oh, but you can tell. Look at where my pelvis is. Imagine the rest of my pelvis. Here's my other leg. Opposite. My left is the patient's right. That is a right femur. If I did not give you part of the pelvis, or if you couldn't see part of the soft tissue, yes, you would not be able to tell which femur that is. But there is extra information. There's the other leg. The other leg of the soft tissue is right there. So you can't tell. Yes?
With comminuted, are you still on the medial and lateral displacement?
We haven't gotten there yet. We will talk about describing the displacement in just a little bit. I like that you're thinking that way. We will get there in just a second. Everybody see why I know that's the right femur? Right? Use the full picture. Don't just look at the bone. And just remember, opposite. Your left is their right, your right is their left when it comes to X-ray and CTs. So here's a good picture of that butterfly fragment with the blue arrow. It looks like a butterfly wing if you use your imagination. Right? So these are comminuted fractures. Here I could just say it's a both bone comminuted fracture on the lower leg. I could also say comminuted fracture of both the tibia and the fibula. Right? But the tibia is more mid-shaft. The fibula, I would say it's right on that border zone of proximal or mid-shaft, right? If I give you one on the test and we look at it, it'll be clearly proximal, clearly mid-shaft, or clearly distal. I'm not going to give you something kind of in a gray area and you got to be like, well, where's the 1/3 mark and when does it become mid-shaft? It'll be very obvious where it's at, okay? And then which bone is this? On the hip? Humerus. Okay? Comminuted, I got 1, 2, and 3 right there, the black arrow. 1, 2, and 3. Comminuted. More than 2 pieces. 1, 2, 3, 1, 2, and that little fleck is 3 on the fibula as well. 1, 2, 3. No matter how small the fleck of bone, it counts as its own piece. And if you look really carefully at the butterfly, you can see that fracture line goes all the way through the tibia there. And that's what makes these 2 separate pieces, and then the little butterfly fragment, the third, comminuted. Yeah, don't get hung up on butterfly fragment for this course. Ortho might care more about it than I do. They're all comminuted fractures. Now here are some of the words that we're going to use. And now to answer your question as far as displacement goes, right, with comminuted fractures, if it's easy to explain and paint the picture, go ahead and use it. So for right here, right, I'd be okay on this fibula to turn around and say that it is mildly medially displaced because we name it for the lower portion of the fragment, just like we do the joints, right? Distal portion is how we name the movement, just like we do dislocations. So that's at least something that's together, which just makes it that much easier to confuse displacement and dislocation because we name them the same way. So the first one is non-displaced. Why is it non-displaced? If I were to draw my lines of the femur on each side and draw it straight down, if there was no fracture there, there's no movement to the bone. That's non-displaced. It is in line where it's supposed to be. It is not moved. In Bravo, we have medial displacement because the distal fragment is shifted medially. How do I know it's medial? Well, look, here's my femoral head, so I know that goes into the medial portion of the pelvis. So that's how I know it's moved medially. Charlie is lateral displacement. Okay. Delta, don't get so hung up on it here. It's called distracted. That's basically where the muscles have been pulling the bone away from one another. It doesn't happen very often, right, in a fracture. It's something that you're probably going to do at some point to try to get it back in alignment, but technically it's distracted. There's multiple ways to call echo, okay? Multiple ways. This has overriding with posterior and superior displacements. So you can just turn around and say, shortening is probably what I would use on this fracture. I have so it's going to be a right femur, I have a right femur simple fracture that is shortened and medially displaced. You can say posterior if you want to, if we had a lateral, right? This we can tell you it's posterior because it's a drawing, so it shows it clearly posterior, but if you just have the x-ray, that's not enough. Remember, we need that lateral to see if it's anterior or posterior to the 2D image. I see some looks. What questions do you have on this? No? And then if foxtrot is distracted and rotated laterally, don't get hung up on rotated laterally or medially, right? I don't need you to do that for this course, but rotation is important. How do I know it's rotated? Well, look at how the femur is supposed to look, and now look at down here. Look at that femur. It almost looks like it's a side view as opposed to a frontal view of the superior part of the femur. The biggest key with this is naming displacement is based off of the distal fragment. Just like naming dislocation is based off of the distal bone. Okay? Yes, sir.
You're saying there can be other combinations as well, like it can be distracted and medially.
Yeah, any of these can really be combined. I mean, medial and lateral really can't, but like any of these other ones can really be combined. So you can get a fraction, you can add all these words together. If you got enough to look at it, you can add in, like I said, I have a right femur simple fracture that's medially displaced, posteriorly, and superiorly displaced, right? Or just say shortened instead of superiorly displaced, because shortened will mean the same thing, and then I'm going to say medial and posterior. Like you can add all these words together. So whatever you can do to paint a pretty picture for the person who's trying to understand what's going on, primarily ortho. Other questions? Yeah.
I was curious, so it says rotated laterally, or how do we know whether it's rotated laterally or medially if it's 180?
Don't get hung up on it, right? Stay on the lily pads on that one. So, I get what you're saying. Now how you're gonna know by x-ray, you probably won't, but when you see the patient in clinic, you're gonna know. Right? If you're in the ER and you look at their leg, you're like, oh, well, your leg's this way. Yeah, so then obviously it's, rotated medially in that aspect. So you'll know that's more of a physical exam to go along with the x-ray, but don't worry about trying to pull that out just on x-ray. All right, so now some other words. Transverse, straight across. So now I have a simple transverse femur fracture, right femur, right? I can see my pubic rami and symphysis, so I know how the body's supposed to look, so I can tell you that's a right femur. I cannot tell you which tib fib this is, because I don't have enough information. So I have a simple transverse femur fracture. Here I have an oblique mid-shaft tibia fracture. You see how it's oblique? So again, oblique, just follow lines. Transverse straight across, oblique at an angle. Now you get this fun one, this little spiral one. This is one of the few x-rays that almost makes it look 3D. You see how we got some bone, and then you got like some darker here, a little bit of darker area there. It almost looks like somebody like twisted the bone and broke it off, right? That's a spiral fracture. It's not oblique anymore because it's been twisted and broken, so it's spiral. And you got that levels of depth in the main fracture here, here, and here. Another key to that is mechanism of injury. If I was running and I stepped in a hole and I twisted and got hit and heard a snap, that rotational injury is likely going to lead to a spiral fracture. If I'm a little old lady and I'm coming down the stairs and my arm gets caught in the banister and I fall and twist as I fall, probably going to create a spiral fracture. Little old lady want to see more often than the step in the hole and get hit by a football guy. Right. You have a lot of beneficiaries, so I'm tired of this. So don't so what you do when you see an oblique fracture is like, okay, it's oblique. Is this spiral and not oblique? Well, what was the mechanism of injury? If it's in there, if it's in the history, right? But then on top of that, do I have these, like, I call it like a depth to the x-ray? You can see that it's been kind of spiraled and broken off. Clavicle. distal segment is out here. So this clavicle, hopefully you've done it in your head already. First of all, is it simple or common unit? 1, 2, 3. 1, 2, 3. There's no bone that goes that way in that area. So we have common unit, and then we are displaced how? Inferior, and we haven't learned it yet, but I would say shortened as well. Right? How do I know it's short? We'll take a look in a second. So in reality, this piece ends here, so I should have a piece ending. Nope, it ends over here. Right? This piece ends here, the other piece ends in here. I can't just put the two together like a nice little, I would have to pull it out and over, so it's been shortened on itself. We'll learn shorten here in a second. So yeah, so this is inferiorly displaced. Okay, that wasn't a word in the last slide, but in comparison, distal fragment. Don't worry about the degrees of angulation, right? Really, this is the one I want you to focus on, this apex superior. So when you have what looks like, similar common unit here, looks simple to me. I see 1 and 2. I can't really tell if that little piece there is off by itself, so I'm going to call it simple because it just looks like 2 pieces to me, right? And so what I would do here is I would say I have a simple left clavicle fracture, apex superior. What that does is that tells us it's broken, it's forming a point, and it's pointing upwards. Don't get hung up on measuring the angles. This is an old school line of thought. Ortho used to love that, and then too many providers were getting it wrong. So they just said, just tell us which way it's pointing. Just give us apex. We'll figure the rest out when we look at the images. Make sense? Here's where that shortening is, another very picture of the shortening. When the bones overlap where the fracture is at, kind of like the clavicle we just looked at. So here I would say again, shortened and medially displaced. How do I know this is rotated? Well, I have an AP view of my tib fib and a lateral picture of my ankle. That should not happen. And again, you'll probably see that in clinic before you do the x-ray. And then when we get to the lower extremity one, you'll see these films of what an AP looks like, what a lateral looks like. So you're like, those two don't go together. Right? So rotate and shorten. Open versus closed fracture. As we talked about before, any fracture with exposed skin, like a scab, bleeding, anything that broke the skin counts as an open fracture. What are some ways I can tell on an x-ray if I haven't seen the patient yet? Because sometimes you have a really efficient team who will see a patient coming in for an injury, especially if you're working in the ER or the urgent care, and the nurses or the techs will order the x-ray already, or you'll notice, hey, tomorrow you got somebody who said they had an injury in their shoulder, and you know you're going to get an x-ray anyways, so you'll call the patient, you'll say, hey, come in 30 minutes early, go to radiology, get your x-ray, so I have the film before you get in. This will be like after you've been practicing for a little bit, you figure out how to streamline things, right? And you'll get the x-ray before you even see the patient. So, a hint on whether or not this is probably an open fracture versus a closed one is the shrapnel, in this case. Now the question is, do y'all see the fracture? Because the cortex doesn't look too bad, especially considering the main cortex irregularity is sitting behind this piece of shrapnel. But look at my medullary canal. And even this going down into here, it does go into the cortex. It doesn't come all the way to the edge. Right? But this down here would be really easy to miss if you focused on the big shiny object, literally, in the x-ray, right? So that's why you got to go through your whole process. And then, what don't we know? What if a piece of shrapnel had come into here? And we haven't learned chest stuff yet, that's block 2. But you definitely would want to look into like pneumothorax or something like that, because what if a piece broke off and shot down here into the chest cavity and caused some issues? So make sure you're looking at everything on the image. So let's take a look at these two images. Can you tell me, without knowing any information, if image 1 on the left is an open or closed fracture? Open. Why open? Yeah, the bone's sticking out of the soft tissue, guys. All right, good. All right, that's an easy one. What about image 2? Open or closed? Open or closed? I heard some say closed, I heard some say open. I want to draw your attention to the lateral image, the one that clearly shows the break, and I want you to go through your process and pay close attention when we go to the soft tissue. And follow the line of the soft tissue now and see if you notice any abnormalities. Do you see it now? Do you see the little notch and divot in the soft tissue right here? See how you got that little triangle piece right there? Do you see it? Primarily right there. What that is that is a break in the soft tissue. When they fractured this, that's one of the reasons I thought in the beginning, the bone came out and went back in. That is an open fracture. Now again, you're looking at me going, this is silly, because I know it's an open fracture, because I'm going to see the patient, and I'm going to see the big hole in their arm from where the bone came out and went back in. You would be surprised how many open fractures have just a speck of blood. Because the body closes it right back up again, because that bone was sharp. So just right back in, right? So this is one of those key things of why looking at the soft tissue is important, and you don't want to overlook looking at the soft tissue, because you might notice the difference between open versus closed fracture. Can we see it? If not, bring it up to me on the break, I'll zoom it in for you, right? You can zoom on this test. Any questions about naming fractures? Open, closed, directional, transverse, oblique, spiral, common unit, simple, any of that stuff? Yes, for sure. How would we describe it? Give it a try. So I would say that's probably mid-shaft femur. So I would just say shortened. If you wanted to say and medially displaced, you can, because the distal portion is medial compared to the proximal portion, right? Because you're naming it based off of the directionality in comparison with the proximal piece. So you could say shortened and medially displaced if you want, but shortening in itself means it's displaced. Like, we know it's displaced, because you can't have something that's shortened and not displaced. So either one would be okay here. If you're describing it to somebody, you could say a simple mid-shaft femur fracture that is shortened, or shortened and medially displaced.
But how is it going to look on the test? Are we going to see, like, it's going to just be mid-shaft, shortened femur fracture?
So if I were to give you that, then I would not also give you shortened and medially displaced. Does that make sense?
Yeah.
I can't give you more than one right answer. So if I'm saying like either one is okay, well then if it's on the test, only one of those options will be present, right? Does that answer your question? If not, ask me again. It's okay.
And I'm just trying to wrap my head around this.
Yeah.
It almost looks like the lower half stays still in the top half.
See, right, perfect. So he's like, it almost looks like the lower half stayed still and the top half moved. I can respect that, right? Take that thought, throw it away. That comment right there, right, is exactly why they went to a standard naming system. Instead of trying to figure out how you see it versus how he sees it versus how she sees it, right? Now we're not speaking the same language, and it gets confusing, which is why they've thrown out how it looks, and they've just said, name it for the distal portion compared to the proximal portion. So we're all talking the same language. You're probably right. This is probably what moved out. But that doesn't matter, because that's not how we name things. And because we don't know, we weren't there for the injury. Right? We don't know the mechanism, we weren't there when it happened, right? So we just make it simple, distal compared to proximal, regardless of what we think is out of place, right? We don't care which part is out of place. we care that it is displaced, and then we describe it, it's distal compared to the proximal section. Does that make sense?
Yes.
Okay, I wanna make sure that's clear, because I know it's very confusing. Like, I respect that it's very confusing, same thing with dislocations. Because our brain wants us to understand how things happen and what moved where it's not supposed to go. Like, that's part of our human logic when we're trying to fix things, right? But that can be interpreted differently per person. Salter-Harris. Salter-Harris is a classification of physiofractures. What is the only patient populations that have physes? Pediatrics. Pediatrics. You cannot have this in an adult. So if you have an x-ray without a physes and without a growth plate, as an adult, don't choose Salter-Harris as the fracture, because it's not possible. There will probably be a choice somewhere. Make sure you understand that this is just pediatrics. That's when you get distracted. Okay, so this is an animated picture, and I understand that. We will look at a couple of x-rays, right? I'm going to break down kind of the Salter-Harris classifications. Type 2 is the most common. The next slide breaks it down better. So when I go into that one, I'll really kind of show you what we're looking at. For this course, and for most of your radiological experience in life, you are almost never going to be able to pull out 1 and 5 on an x-ray unless it's extreme. I have a couple of extreme ones in here just so you can kind of see what it looks like, but you can almost never pull them out because they're so detailed and small and finite, they're really difficult, and that's why we have pediatric radiologists. However, 2, 3, and 4, you'll be able to pull out. Why do I have this flipped and upside down? Anybody know? How's the x-ray gonna look? I don't know, right? And the relationship is not based off of the direction, it's based off of the anatomy with the metaphysis, the epiphysis, and the physes in the center. Okay? So, this is the one that I like that really describes it. So when you kind of put these two together, you can kind of get an idea of what the Salter-Harris looks like. Why is it pronounced Salter? It's pronounced Salter because of the names of the different types. Type 1 is slipped. So the fracture is just straight through the growth plate. And I'll go right here. It's right here. Now, how the heck do I see a fracture that's through a growth plate on an x-ray? That's really hard to do, right? So what I would say is if you have a pediatric and like the bones over here, like the top part, the metaphysis is over here, and the epiphysis is in here, right? Metaphysis is in this area, and the epiphysis is where it's supposed to be, then you'll know it kind of slipped. We'll look at some extreme x-rays of that, but it's really hard to see. So you need to know what Salter-Harris 1 is. That's the S for a slipped physes, okay? But I'm probably not going to make you just pick it out on an x-ray. A for type 2 is through the growth plate. All of these go through the growth plate. You cannot have a Salter-Harris fracture if the growth plate is not fractured, right? So it's through the growth plate and then away from the physes. Okay, so if I go back here, 2 is through the growth plate and away. Or what some people like to know it, they like to know it by the bones, it goes through the metaphysis. Type 2 goes through the metaphysis. Through the growth plate and through there. Now this is where you kind of can get confusing because look at type 2. It's going not necessarily away, but L for lower, which is what type 3 is, which is why I just know my metaphysis and epiphysis and my physes, and that's how I learned it. But some people learn it with the Salter-Harris, slipped away. Next one's going to be lower. We'll get to that in a second. Everybody see how it goes through the growth plate and then up through the metaphysis or away. Number 3 is L for Salter. It's lower. So growth plate and low. Growth plate and lower through the epiphysis. Oop. So through growth plate and lower. Growth plate and lower through the epiphysis. That can get confusing if it's this way when it goes up. So that's why, again, I learned it from a bone standpoint. Epiphysis, metaphysis, physes. So type 3 is through the epiphysis. All right? Type 4 is the easiest one to know. T for through. It goes through both. Start here, just goes through both. When I look at my little cartoon, right? Straight through both the metaphysis and the epiphysis, which means the most challenging thing you have in Salter Harris's is when you see something that you think is a type 2 or a type 3, do not stop. Look at the other part. Make sure it's not through the other piece as well. Because if it is, then it becomes a type 4. Because it's through both pieces. Most common in this course the confusion comes to, you guys get really good like at notifying, like recognizing the 2s and the 3s, and you completely overlook looking for the 4. And so again, you get excited. You're like, I know this one, that's a type 3, and you click it, and then if you looked at the whole thing, you would have found that it's through the other section as well, and it was actually a 4. So make sure you do your full read. And then type 5 is R. I know it says Salter, but they just wanted to make it spelled nicely. But R for reduced. That's when the bone gets crushed on itself. Okay, hence the cartoon being crushed. But you can't be, I mean, it's got the fracture through the physes just like the slipped one, but it's just crushed. It's extremely uncommon. You're not going to be able to pull out an x-ray. I'm not going to make you pull that out on an x-ray. Which means nobody in this course better pick Salter Harris 5. We just told you I'm never going to unless it's like a straight up question of which one of the Salter Harris fractures is considered a reduced fracture, right? That's a straightforward first order question, not interpreting the film. So, questions on Salter Harris for now. I know. Here's what it kind of looks like in x-rays. Okay, I know there's blue lines through the fractures, but there'll be other ones without it. I just want you to be able to see kind of the picture of the ankle and kind of what areas of the bone each one goes to. One is slipped, right? Kind of hard to tell. I get it, but that's what 1 is. 2 is away. 3 is lower. 4 is through. 5 is reduced. You are not often going to see the fracture within the growth plate because there's a space there. So how the heck do you know? Well, if the fracture is in the bone and it touches any area of the growth plate, you assume it's a Salter Harris. Because energy's got to go somewhere. So when the fracture came down, it went through the growth plate and it fractured. So if there's a fracture that touches the growth plate is involved. Here's some more without the pretty blue lines. So this is your Salter 1. See how I got some extreme ones? It's slipped over. This should be lined up with the edge of the bone over here. The epiphysis should be lined up with the metaphysis over here, and it's not. Like, what? Over here. Oops. Right? How do I know it's a Salter 1? Well, A, it's shifted over, and B, when I look for a fracture in either of my bone pieces, I don't have one. Okay? Does everybody see how it's slipped over? It almost looks like somebody just took their finger and just pushed it over. Okay? Here, what do we have? Salter Harris what? 2, not a 3. Right? Even though it's going down, right? Look at the direction it is, epiphysis and metaphysis. This is a Salter Harris 2. I can't see that fracture in the growth plate, but I have the fracture, that line that goes up into it. That is a Salter Harris. So now knowing that, if I look over here at the ulna, what do you call this one, Salter Harris? It's not. Trick question. It doesn't involve the growth plate. It's not a Salter Harris. It has to involve the growth plate. This would just be a simple incomplete fracture, probably green stick on the ulna. It's kind of got that little bendy area to it. Maybe, let me get closer. All the way through? Yeah, you could argue that it might be all the way through, but either way, it's a simple fracture, right? But it is not Salter Harris because it doesn't involve the growth plate. That's just the shaft of the bone. Over here, I got my 3. I know the yellow line goes above, but it's just so that way it doesn't cover up the whole fracture. 3. lower, right here through the epiphysis. And then here's my 4. Through both bones on the Salter 4. Can you now appreciate each of the Salter Harrises, at least with these pictures, and kind of what they look like? Questions? I did not give a 5 for a reason. Okay. All right. So if I have a 10-year-old who fell from the top of the playground about 10 feet onto an outstretched arm, how am I going to describe all of the abnormalities that are on this film? Somebody give me a stab at one of them. Just pick out one. What would you call it?
Got a simple,
Okay.
shortened, distal ulnar fracture.
Ulnar or radius? This is going to be your radius here. It's on the wrong side, right? Remember now, so the way I always remember when I'm looking at x-rays, right? The radius is smaller at the elbow than it is at the wrist, and the ulna is bigger at the elbow than it is at the wrist. So I always have to take a moment. I don't know if you notice here, I'm looking at it. Before I say it, I'm taking a minute, I'm doing that in my head, going, is this radius or is this ulna? Right? Is knowing that the ulna is small at the wrist and the radius is big at the wrist, and it's vice versa at the elbow. That's how I always kind of looking at the bones, because it's a kid who fractured it. So ideally we would like them like this, but if they can't and they're just sitting like this, we're still going to get the x-ray. So knowing what the bones looks like is important. But I like the simple, shortened. We could add in there, if we're going to add displaced, we would have to add, because it's hand and wrist, ulnar displaced, right? We can't use medial and lateral when it comes to the hand and wrist because of what we just talked about. But I'm okay with just shortened. So good, we got a simple, okay, we got a simple radial fracture that's shortened, distal. Thank you for doing the region of the bone. All right, what else we got? Ulnar green stick, okay. I heard ulnar green stick right there. Good. What else? Anybody see anything else?
Sir, I've got a question.
Yeah.
So with the radius and the deviation, because the part that's not attached, the distal portion of the radius is farther to the, on this picture, to the left compared to the rest of the attached radius, wouldn't that be a radial deviation instead of a...
Remember, we named it for the oh, yeah, good catch. Thank you. Thank you. See how confusing this can get? Right? I'm not going to give you a 4 on that, but you're right. So this is actually the distal portion.
Yeah.
So for those who are going, hey, it should have been radially displaced, you were correct. I misspoke. Thank you for that. Did everybody realize that this is the distal fragment here? Not this. Is it open? Maybe, right? Here's the challenge with this one here. What can't I see on the other side of the bone? Soft tissue. Is that because that bone is sticking out of the soft tissue, or is that because the tech used a little bit more radiation than they should and it burned out that soft tissue? I don't know that, but I will when I see the patient, right? I will when I see the patient. Does anybody see the Salter Harris 1? Look at where the epiphysis is, and look at where the metaphysis is. This thing has slipped completely off. This is your ulna on your lateral. It's supposed to be sitting over here with the epiphysis. So this is also a Salter Harris 1.
So would it be
It's
named?
completely slipped off.
Would it be named ulnar green stick with a type 1 Salter Harris?
Yeah, I'd be good with that. I'd be good with saying distal ulnar green stick with type 1 Salter Harris. I am not going to give you anything this complex on the exam. I can't, right? I can't give you 4 abnormalities and say describe it. How do I do that with only one answer choice, right? I can't. But these are all types of abnormalities you could see. You could see a green stick. You could see a Salter Harris. You could see simple or common-unit displacement, right? It's just kind of putting all into one picture. But for a test question, I can't expect you to describe all of this. I could give you this question, or I could give you this picture, right? And only make one of these abnormalities a correct answer and give you 4 ones that aren't even on this film. Right? I could give you a green stick ulnar fracture and then say nightstick radial fracture, which nightstick's only in adults, so that makes that wrong. I could tell you it's a tib fib, and that's wrong because anatomy-wise, right? I could say common unit radial fracture, and that would be wrong because that's not right. And I could say Salter-Harris 3 ulnar. There's still only one right answer with all the abnormalities on this film that match up with that. But what I can't have you do is explain every single abnormality on this on a test question. There's just no way. I can put all 4 of them on. Just have to get the points back. Yeah, no, so I'm not a big fan of negative STEM questions, right? Technically, we are allowed a couple. I don't like them, so I try to avoid them. So if you see one, I apologize. I try to remove all those. I hate negative STEM questions. There's 4 right answers and 1 wrong one. Which one is the wrong one? I think it's backwards. Right. All right. 50-year-old caught her arm in the rail, rotated on the stairs when she slipped and missed a step. What best describes the fracture in the image? Take your time, read them real quick, look at the picture, and let me know what you think. This is where I can put a bunch of words together to describe one fracture. And we're going to practice our test-taking techniques on this one. All right. I'd like you to try to add this 1 minute question. So, all right, let's move on. Okay, so test-taking techniques. What is the first word in all of the answers? not the vignettes, the answers. Either common unit or simple. So my first step is, can I determine if this is common unit or simple? Because if I can do that, I can already eliminate multiple answers. So what is it? Simple. So alpha and delta are out automatically. I just narrowed this down to 3 without even really thinking about it, just by looking at the simple or common unit. Now I went from a 20% chance of guessing to a 33% chance of guessing. Hopefully it'll be 100% by the end. Okay, so now the next thing I have is, I'm going to skip to the end of the answer. What bone am I looking at? Humerus. Can I rule those out? Nope, they all say humerus. Good. Okay, we're moving on. We're still at 3. We're still at 3. Well, right, well, we've already ruled out delta because it's common unit, but that's what I was looking for. Because one was say femoral. I could rule that out. We already did. All right, so now my next thing, I got oblique, distal, proximal. Okay, well, is that distal, proximal, mid-shaft? What is that? Proximal. So now I think I just found the answer. But I'm not going to stop reading and click it. I'm going to make sure. So the next word is spiral. We have the mechanism of injury, but did you notice it on the fracture that it was spiral as opposed to just oblique? Did you look at the depth primarily in this portion of the humerus up here? Right? So we have a couple of different things that would throw you off on distractors. B, C, and D are all simple, right? Sure, distal proximal is great, but then I have my type of fracture. I have spiral and oblique. So there's your distractor of oblique versus spiral. That's how we can understand the difference between those two. And then distal versus proximal, right? Knowing the location. Those are going to be yours. How many got it right? It's okay if you didn't yet. We're still learning this stuff. It is echo. Simple, proximal, spiral, femoral fracture. But you see how we broke that down by words, right? So it's not so overwhelming to have to read everything all the way. Just read all the way through, especially when you think you found the right answer. And so is it rotated? I really don't know. But do you see rotated in any of the answers? Then I don't care. Because I don't need to know that to get the 2 points for this. All right, one more and then we'll take a break. 17-year-old male fell down the stairs, sustained a lower extremity injury. You note some small lacerations on the medial aspect of the lower extremity. Based on the image and physical exam, what's the best description of the injury? So we're just gonna run through this so we can get you guys on a break. So if I said there's small lacerations, I already know it's open. I just dropped it down to 2 answers. And I haven't even really put a lot of brain power into it yet. So now I got open. So now I can go distal or proximal. Well, more distal than proximal, right? Could that be mid-shaft?
Yeah.
Could be, but did I give you mid-shaft as an answer? Great. So then we know it doesn't matter if it's in the gray area. So now we've gone distal. I'm like, okay, well, I think I narrowed down to 1, but let me just make sure. Is it comminuted? Yes, it is. Is it the tibia and the fibula? Yes, it is. The answer is alpha, an open distal comminuted tibial fibula fracture. You see the kind of stuff that I would be looking for if I were asking you to pull stuff out. Not all of them are going to be this obvious, right? Then I would get in trouble for like a 98 average, and that's not it. I'd be okay with it too. And then like, everybody's for it? All right, well, what the heck? What do I get, 5 minutes? All right, we'll come back to that one in a second. Take 10, come back to the top of the hour. Before we go into the next lecture. All right. Salter Harris is confusing. I know it is, right? Take your time to try to look at it at some point this week. Please bring me all your questions. I know that can be difficult to see and kind of track. It's probably one of the more challenging sections of this block is understanding those Salter Harris and trying to figure out where they go, seeing them. Use Radiopedia. When you use Radiopedia, please don't just type Salter Harris. The more specific you are, the better. Tell yourself, I want to get better at Salter Harris 2s, and type in Salter Harris 2. Look at those. Then look at 3s and look at 4s. If you just type in Salter Harris, you are going to get all kinds of 1s. You're going to get 1s and 5s and all that. Focus on the one you want to focus on, learn that one, and then look at a different one. All right? Speaking of Salter Harris's, we have a 9-year-old who landed wrong on a trampoline. Which best describes this fracture? This isn't the test, so Salter Harris 5 is in play. This is not the test, so it's in play. On the test, if it's just an image, see, I do that just to see. No, it's not 5. No, I'll tell you now, it's not 5. But take a look, right? How many say Salter Harris 5? Good. Oh, you guys got the papers? You guys got little papers? No, that was just from last semester?
Irving didn't teach us.
No, boo. Oh, that's right, those were from Irving, weren't they? Oh, so sad. Okay, anyways, he's still alive. He's just not here. I just realized how that sounded. He's still on this earth. Oh, my. How many say Salter Harris 1? I'm just going to go in order. All right. How many say 2? Couple of 2s. Anybody for 3? No 3s? 4s? Okay, 4s. Yeah, be confident. You're going to be wrong, be confidently wrong. All right. It is a 1. Salter Harris 1. So, 2, we have a fracture through the metaphysis. So when I go through and I'm looking, and I'm doing my method, I don't see any fracture through my metaphysis that involves the joint. I will buy that maybe some people might have found this line here, maybe thought, or maybe this line here in the medullary canal area, but nothing that comes up into the actual growth plate. And if you look at this, the humeral head, it looks like it just slipped right off, like an ice cream cone, just kind of popped off. Go ahead. Right off. Maybe that's your computer. No, no. Hey, that's fair. That's fair. Yeah. So some people are saying this right here. Is this what all the 2s were seeing? Yeah. So, yeah, go ahead. Here? Yeah, so what that is, that's the other side of the growth plate when it's shifted over. That's just the way it's looking from right here. This is all the growth plate here, so that's the other part of the femoral head that has slipped over. This part, right here, that's going to be your lesser tubercle area. Yep, good question. I like that, right? So ask that stuff. You see what's happening around that one? I don't see that one there, but that's okay. Yes, so that's a good point, right? Try not to, as I always try not to overread, right? Try not to overread. Don't make yourself see things that aren't there. I know, and that's okay. Is this all the hair? Okay, so now we're going to briefly describe fractures in different stages of healing real quick, and then we'll be finally done with this slideshow. I promise you, that NSK 4 and 5 go a lot faster, right? They will. You gotta know all this stuff before you do the other stuff. Okay, so this is for your review, right? From A&P stuff, as far as how bones heal and all that jazz. We kind of saw what it looked like on X-ray before. I'm not asking anything from this slide. It's like the anatomy slides, right? It's FYI at the top. It's just so you understand the process. There are lots of things that can affect fracture healing: delayed union, non-union, malunion. Okay? A non-union fracture is a fracture that does not occur, it does not heal within 6 to 9 months. Okay? Not 6 weeks, not 8 weeks, not 12 weeks, 6 to 9 months. If it has not healed altogether, that is considered a non-union. A malunion is a fracture that healed together, but it didn't heal in the appropriate anatomical position. We'll look and see what that looks like. It's healed, it's all one bone, but it's not the shape that it's supposed to be. It's not in the position it should. That's a malunion. Okay? So we already looked at this. Here's your periosteal reaction, right? This is likely from a small hairline fracture. It's very minimal. It looks more prevalent on some of those pediatric ones, some of those other x-rays we looked at, but that just tells you that there was a fracture there that is healing. Here's a delayed union. So this is a fracture that's taking about twice as long as normal to heal. Okay? That's a definition type thing. I'm not getting into time frames of how long it's supposed to heal. You need to know the non-union, 6 to 9 months. That's a really long time. Most fractures are like 6 to 12 weeks. Ortho will get into that. But I want you to know that a delayed union is a fracture that takes twice as long to heal at a specific location because every bone's different. Right? And ortho will dive more into that. Here's your non-union. This is healed in the aspect to where I healed it into 2 separate bones. It's non-union. How do I know it's non-union? Well, based off of this picture, I don't. But if this fracture happened, say, 8 months ago, 10 months ago, 12 months ago, and this is still the picture I have, that's a non-union. Another way to tell is going back to that scaphoid that we saw before, how it was like 2 separate bones. You could trace the smooth cortex between each piece, and it had been a prolonged period of time, at 6 to 9 months. That's how you know that's a non-union. It healed together, but it didn't heal, but it healed separately and not together as one bone. It's a great questions for definitions. Malunion. This bone is completely healed. There will be no more healing that will take place in this stage. This is what it looks like now. It's healing not in the appropriate anatomic position. Now, if this isn't painful and it's not limiting their activities, this is fine. We'll leave it alone. There is no reason to do anything about this. Just because it looks funky, if they're still able to do their life, their job, their hobbies, and they're not having any pain, hey, you're healed, have a good day. Now, if they're not able to do their stuff, they're having pain, or they're not able to do their activities, their hobbies, their job, that stuff, That's gonna need to go to ortho. They're gonna need to re-break that bone, set it again, probably put some hardware in this time, and get it to heal like it's supposed to. But that's only if it's affecting their life. Otherwise, just gonna have a funky bone bump for the rest of their life. Not a big deal. But that's your malunion. So what's this one? That is a malunion. Why? It's one bone piece. Look at my cornea. This comes along. This is connected here. This thing healed together. Now, why did it get like this? Why didn't they set this? I don't have an answer for you. I just know that it was a good malunion picture. This is got, maybe, I don't know why they didn't go to the doctor, why they didn't get surgery. I don't have an answer for that. Everybody always asks me, and I have no idea. But that's connected into one piece. Even though it's in two separate spots, that's all bone in there. That's all one bone now. That's a malunion. It has come together, but not in the right position. Yeah, that's just a fact. I just like that. How do I describe this one? Let's see. Yeah. So this is an open, comminuted mid-shaft tibia fracture with 45 degrees of apex anterior angulation and segmental fibula fracture. You guys can pull that out on a test, right? If I put that as too long to be wrong, if I just put all that and just say like simple, no. It's not going to be that involved, but that's just going to show you, it's in the notes, and for those of you that have the notes, like how this is, that just goes to show you like how detailed you can get. So for some of those people, like, can I use more than one word to describe it? Yeah, if it fits, go ahead. Do I expect you guys to say all that? No, I don't. But it can get quite involved. What type of imaging is this? CT, good. What plane? What slice? What plane? Sagittal, double good. What's going on here?
It's metal, it's the shadow from
Right, it's the artifact from the shrapnel, from the bullet wound. Not air. Air is black on X-ray and CT, but we know it's not air. At least we can't call it air because I have the metal in there that could be causing the artifact. Could there be air in there? Yeah, there could be, because obviously this got in there from the outside. All right, so there could be air in there, but I can't tell because I have artifact in the metal. This is a shrapnel wound. Here's your fracture on the tibia. And there's probably a lot more. There's one right there in the posterior aspect. Now there's probably a lot more going on here that I can't see. Don't order an MRI. Contrary to popular belief, it is not the easiest way to get the shrapnel out. It will come out, but probably not what you want to do. Questions on that really lengthy, thick slideshow? Okay. Yeah, we're not done. Gotta go to the next one. Okay. We're going to do more abnormality stuff. Yeah, did you have a question?
I do.
Go for it.
The delayed union.
Delayed
and
union and the malunion, yes.
Those look really similar.
They look really similar, correct. The difference is going to be tiny. A delayed union, we haven't given enough time to appropriately heal, and it should be healed with, it could take up to twice as long. And so that's still only going to be about half the time from a malunion. So those aren't great image questions. If I give you an image on those, it'll probably be adjunct, but there should be enough in the actual question for you to distinguish between what is what. Yeah. So sometimes there will be images on the test that are not needed to even answer the question. They're just there to provide adjunct. Other questions? All right. We're going to do some more of this. We'll do some skull. All right. Joint disease. Did you know that you can't see arthritises on X-ray if they're advanced? If they're advanced. Osteoarthritis, you can see with its advanced psoriatic arthritis, rheumatoid arthritis, you can see all of these things. And sometimes the x-ray is what's going to lead you towards a diagnosis because you don't even know they have it until you get the x-ray. We're going to talk about some of those. A couple of different types of arthritis. We have hypertrophic, erosive, and then the nasty, scary one, the infectious or the septic. Okay? There's a little radiopedia that kind of breaks apart all the hand arthropathies, that word, arthropathies, if you want to use it. For those that like diagrams and charts. There we go. This is a normal structure of a joint. Your normal anatomy, you should have this lovely joint space in between the two bones. Right? They shouldn't be sitting on one another. That's where this joint fluid is. You see the little space where the fluid is supposed to be. This is a nice healthy knee x-ray. Look next to the picture of what a joint is supposed to look like. Remember, you can't break a joint, you can only dislocate it. What type of imaging is this? That's an MRI. What slice? What's it called? The back thing. Coronal.
There we go.
This is a coronal slice of an MRI. How do I know it's an MRI? Well, look at all my joint fluid I can see really bright on here. Look at all that, right? And then look at the definition I have between two different types of soft tissue, between my skin, and my subcutaneous, and my muscle, right? I can tell the difference between the two. On a CT, you really can't. Maybe a slightly different shade of gray, but not like a significant difference in that soft tissue. And you're not seeing any kind of fluid on a CT without like a contrast or anything like that. So this is an MRI. This is where it kind of shows you the joint fluids and the cartilage. Look at, I'm not gonna make you read it, but look, I can see that thin line of cartilage here on an MRI. That's why these are so good. Thin line of cartilage. This bright white in here just happens to be all the joint fluid. You can see the thin gray line of the cartilage on both sides. So, just to give you an idea of why sometimes they do the MRIs. Here are the 4 primary hypertrophic arthritises we're going to cover. Primary, secondary, erosive, and Charcot's. Charcot, not Charcot. Charcot. Its E is silent. It's like pterodactyl with the P is silent. Alright. So osteoarthritis, the most common form of arthritis, right? Almost all of us are going to get this at some point in our lives because we chose to raise our hand and serve our country. You're welcome. Enjoy your arthritis. Hopefully it holds off until you're older, but you're all probably going to get it. Usually in the hips, knees, and hands. Weight-bearing joints are the most common, and yes, the hands are a weight-bearing joint, especially if you think about like mechanics, right? Those airplane mechanics, like those are weight-bearing. They're gripping the tools. They're doing a lot of wrench turning and all that, so that'll work. Symptoms are uncommon before the age of 40 in most people. We are 1% of the population. We are not most people. So yes, you can find osteoarthritis in active duty members prior to age 40, but in most people, age 40, right? And typically, it's bilateral involvement for your primary osteoarthritis. X-ray is your study of choice because we're looking at the bones and the joints. So X-ray is your study of choice for osteoarthritis. There's some other things you can find. The osteophytes we're going to look at. All these other things we're going to take a look at. There is a difference between primary and secondary. Primary osteoarthritis, right? Nothing happened to you. You just got it from years and years of use and abuse and old age. Right? Old age. How do we notice arthritis? Well, biggest thing is these osteophytes on here. There's your osteophytes. There's your osteophytes. Joint space narrowing. Now I want you to look at this knee picture. Okay? Look at the joint space. Look at the normal joint space. These arthritises is where it's a lot easier to pull up an image of a normal knee x-ray and then pull up an image of somebody who has osteoarthritis or any kind of arthritis in the knee. because then you can appreciate what the normal joint spacing should be versus the narrowing that we're having right here. There's almost no joint space here. Okay, here's some more osteophytes in the femoral head. I respect the fact that in this hip x-ray, the joint space narrowing is very hard to see because it's bright white, but it's there. But to show you, that's more to show you where you're looking for this, okay? But this extra guy, that's not a fracture, that's an osteophyte. These aren't fractures, these are extra little bone growths from inflammation and angerness of the arthritis. So, primary osteoarthritis, old people. Bilateral, right? Typically bilateral. This is from age and it's from use and reuse. Secondary osteoarthritis means something else caused it as opposed to age and just repetitive use. So if you have a young person, if it's unilateral usually or post-traumatic, it's likely secondary osteoarthritis. So where do I get secondary osteoarthritis from? So post-traumatic, torn ACL, any kind of surgery on a joint, right? Any kind of hip surgery, any kind of fracture of an area that involves a joint, a humeral head fracture, a femoral head fracture, or radial head fracture, right? Anything that caused, that was trauma, that caused a fracture or required a surgery is likely going to be secondary osteoarthritis, and they're probably going to be young as well. You're going to get it a lot younger. So how many have had a surgery on a joint in here? Right? You're probably going to get, if you don't already, some arthritis in that particular joint, same, earlier than everybody else. Because we caused trauma by doing surgery on your joint. So it's going to be inflamed, you probably have scar tissue there, you're more prone to that. When you get arthritis in that particular body part that you had surgery on, that is secondary osteoarthritis. If you're lucky and you don't, and both your knees or both your shoulders start hurting at the same time, then it's primary because you got a little bit of that. So how do I distinguish between primary and secondary? Is it bilateral versus unilateral? Was there some kind of trauma? And what's the age? Because if they're older by the time the symptoms start to come on, then it's bilateral, then it's likely primary. So, if I'm in basic training and I'm doing med call, is this likely primary or secondary osteoarthritis? Secondary, right? Young. That or they're just trying to get out of their PT test. I'm not sure which, but you know. It's a lot of crutches for a PT test, so let's hope that they go that way. I don't know how the Army is, but I get to see Air Force people bring in crutches when they don't need it. But I got some eye rolls from the Army, apparently you guys have seen it. The new military, it's okay. Alright, good. So here's another picture of breaking down. Notice how on the image, and all the things I pointed out on the primary osteoarthritis is the same on secondary. The image is not enough to distinguish between the two, you can't tell. Because it looks, it's the same thing, you have the same abnormalities. It's all based off of mechanism and age. That's how you tell the difference between the two. Okay, questions on that one? All right, let's jump into the erosive hypertrophic arthritis. Most commonly in perimenopausal women. Right? So now with these arthritises, and as we go through this, and as you're going back and studying it, there are things with certain ones in the x-rays that are different that help make you jump out, right? But as I talked about, radiology, x-rays are adjunct. You use the images with the information provided to you to make a diagnosis, right? So the image is good, but if you also pay attention to the patient history and the type of patient they are and where it hurts and what they're coming in for, that will help you distinguish between some of these arthritises that we're giving you, but use it with the picture. So if I say perimenopausal women, unless I've given you a trauma of some sort or something along those lines, the odds are like secondary osteoarthritis is probably out the window at this point, based off of the age of the population. On top of that, this is most often in the joints of the fingers, primarily the thumb, or the proximal and distal and phalangeal fingers there. Severe inflammation, joint pain at affected joint. So this may or may not be more than one, but typically it's just a single one. X-ray is still your study of choice. Erythema around the affected joint. Why? Because it's erosive, it's inflamed, it's angry, right? Your regular arthritis you don't really have swollen joints with those. And then the bottom part here, gull wing deformity. Erosion is typically centrally located within the joint, and they have a gull wing deformity. So take a look here. It looks like when you were a little kid and you drew the seagull pictures because we were so proud and wanted to show mom that you could draw a house and a sun and pretty little birdies in the sky, right? That's what this is. Think back to when you drew those pretty little birdies, and your gull wing deformity is your erosive hypertrophic arthritis. And look at the joints. So I like this x-ray because I want you to take a look down here at your carpal metacarpal joints. It typically isn't in your fingers in this one, but this gives you an idea of what the normal joints are supposed to look like as far as spacing and everything goes. And then look at your joints that are affected now when I go into my pivot, my dip joints. Primarily this one, which is magnified, looking for that gull wing deformity. All right, I don't have this nice spacing. It looks like the pretty bird. It's tough. Here, let me take a look at like outside of this ball. I don't trust your screen anymore. Let's look at it. Yeah, so it'll be a better picture as far as size goes, right? I try not to. I mean, you can zoom in, but I try to make it as like more magnified on the image. But if you think it's gull wing deformity, right? You're like, oh, is it? Go back to your patient population. Go back to your symptoms. Did I say there's erythema around the affected joint and the concerning joint? Use it all together, all right? Yes, sir.
Is there a way on X-ray to tell if it's a gull wing deformity for sure versus like the Bouchard's nose and Heberden's nose?
So
Because they do are that if and dip, right?
they are. That's the area, but the Bouchard's nose and the Heberden nose are not necessarily have a significant major bony abnormality per se. But one of the things I can see here that I don't have is in my soft tissue. Am I swollen around those joints? Right? Is there those big nodes kind of sitting there versus not?
But then it also says that this type of arthritis has the severe inflammation and the joint pain and erythema, right?
That's fair. So I'm going to say not that I know of as far as distinguishing between the two. Also in this course we won't discuss those two other things, right, for my testing purpose. But if you see them, you're not wrong for wanting to get the x-ray and then kind of see what else is going on. Because the erosive hypertrophic arthritis could lead to those down the road, maybe. There could be other things going on. But I don't want you to associate those nodes with automatically erosive hypertrophic arthritis or vice versa, right? Because it just depends on the patient. Yeah. Here's another picture. And if you look at this one's more clear, right? You see that gull wing deformity on some of these joints right here on the right one, right? Fourth digit, right? You kind of see it here on the second digit on the left, right? This one's a little more clear. But this is where you get that little gull wing deformity, the erosive hypertrophic arthritis in your dip and your pip joints. Notice again how my carpal metacarpal joints are beautiful and they look wonderful. Which means that they look normal. I'm probably not leaning towards erosive hypertrophic arthritis on this one. Look at these guys. Don't look at these guys. Questions on the seagull? Okay. Charcot. This is going to be one of the ones we're going to look at. Okay. Diabetes. You'll see when you look at the picture, for those of you who are already looking ahead. Diabetes. Diabetes. Read the vignette. Diabetes. If you have a patient with diabetes, primarily the joints of the feet and ankles, you're going to get some of the Charcots. Here's what's interesting about Charcots. You're going to see the x-ray, and the patient will be like, no, I feel fine. And you're going to look at it and be like, you're doing okay. You're like, yeah, no, I feel great. Why? What does diabetes do, especially prolonged diabetes? Neuropathies. They can't feel the pain in their feet and ankles. X-ray is a study of choice, okay, like all these arthropathies are. Ow. They don't feel this. It doesn't hurt. This is bone on bone. This is technically, I could call that even subluxation if I wanted to, because it's kind of shifted over, right? It's not dislocated, subluxated. It's not completely separated. But look at this ankle too. Like, this is Charcot's. Diabetes. Big ow, but no pain, or very minimal pain. So when you finally get that patient, you're like, oh, you hurt your ankle, let me get an x-ray. If they're diabetic, this is not an abnormal thing to see for them. Like, it's abnormal, right? But it's common in diabetic patients. Question on Charcot's. Ma'am.
Why is that whitening that we're seeing around that area?
All this, because it's that hypertrophic arthritis. So it's constant inflammation, constant pain, and when the body, the reason we get arthritis is when the body gets tired of being painful and inflamed, it wants to create things to try to protect it from itself. So this is hypertrophy. This is the body creating, look at all the extra kind of bone and kind of growth that we're having out here. The body is trying to create bone because bones don't typically hurt, to try to protect it from the inflammation. But this is like, if this was like you or me, and this would be extremely painful. Extremely painful. But they don't feel it. Like, I do not walk on this. But they do. And they'll just come right on in. Right? But what does this increase their risk of? Fractures. And then what ends up happening is they come to the doctor for something else, and they step out of the car and they roll their ankle, and now you got a comminuted fracture. Depending how bad the diabetes is, they might have to amputate the foot and the ankle, because if you have neuropathies, it's probably not going to heal very well either. But that's a decision for people who get paid a whole lot more than we do. Any other questions on Charcot's? Right? Diabetes. Ow. But the pain doesn't hurt. CPPD. These are some crystals around the joints. This is FYI. This is still going to be an X-ray study of choice. I'm not going to test you on this one. But what can happen here is when you start to see these guys on an X-ray, right? This is not an MRI. Now, MRI, we saw that fluid in the joints and stuff, right? This is not an MRI. We can't see fluid. This is calcium pyrophosphate deposition disease, CPPD. Okay? And yes, it's correct. It's pyrophosphate for PP deposition, not supposed to be two U's. But this is just calcium that's sitting in the joint that can cause arthritis. So yes, it's an abnormality. There's really not a whole lot you're going to do for that, but you can at least tell the patient, this is why you have it. You have some arthritis from the calcium depositions. I'll let ortho talk about if there is a treatment for it. I don't think I've ever treated it. Just kind of, sometimes just having that knowledge for the patient is enough for them to feel better about it and kind of go about their day. Not cancer, yeah. Right? You can have it kind of in the wrists and stuff too. You can have it with the TCCC in here. You can have it with the hook and the hamate. I'm not going to, again, test you on this. There's different areas where you can find that. Ortho will hit it more next semester. Yeah. Yes. Yes. So this is the same thing as like pseudo-gout. This is the official clinical name of what people call pseudo-gout, right, is the CPPD. How do we know we have pseudo-gout? Well, you can get the x-ray, or what happens if you ever try to do an aspiration of the joint, there won't be any uric acid crystals, they won't see anything, so they're like, oh, it's probably the pseudo-gout. And pseudo-gout is most commonly in the knee, whereas regular gout is most commonly in the big toe, right? First metatarsal phalangeal joint, and we will see some gout x-rays later on. We really only talked about right now, so far, the hypertrophic, but there is the erosive and the infectious. Talked about the 5 types. The first 4 are the ones I need you to know. Distinguish between primary and secondary based off of age and or trauma, and bilateral versus unilateral. We talked about the erosive hypertrophic arthritis, which is that perimenopausal woman, primarily in the dips and pips, that glowing deformity, okay? Alright, think of it this way. Again, I talked about the pictures, you all kind of giggled at it. But really, when you were a little kid, you drew the picture for who? Grandma. Perimenopausal women, right? On the seagull picture. Try to put that together as best you can. And then Charcot with diabetes. Okay. And then the CBD was just FYI for you. Let's get into some of the erosive arthritises. Okay. All 4 of these are fair game. All 4 of these are going to look a little bit different and have their own nuances to them. First one is rheumatoid. This is an autoimmune thing. Okay? So rheumatoid arthritis, lots of things that kind of go into causing it. I'm going to say that for upperclassmen courses, we're not going there. Most commonly in female patients, that doesn't mean that it can't be in males, but most commonly in female patients. And pay attention to the joints here. Proximal joints of the hand and wrist, so sure the PIP is involved, but what's involved that wasn't involved in the erosive hypertrophic? The carpometacarpal joints are involved. Those weren't involved in the other one, right? So there's a distracting distinguishing factor between the two. Minimal joint pain, whereas the other one is pretty significant pain, right? It's erosive, it's inflamed, it's angry. But later on, if it goes unnoticed, it can be debilitating towards the end, and they won't be able to use their joints, okay? X-ray is still the study of choice. X-ray is still the study of choice. And this is what happens with it. All right? We start to get some erosion around the distal portions of the metacarpals. Okay? And then the rest of the phalanges start shifting to the side to support themselves because we're losing some support there. So they will shift over to the ulnar side, ulnar deviation in the proximal joints of the hand and wrist. Usually this is bilateral and symmetric. Okay? X-ray is still the study of choice for RA. And what you end up getting is those fingers start to drift at those carpometacarpal joints. It can be at the pips as well, but most of the time it's at those carpometacarpal joints. It can also affect at the wrist. Look at the carpals on this wrist. See how it's all kind of just muddled together? They're not really good clear joint spaces. I can't really make out the joint space between the radius and the ulna here. It's just all kind of muddled together. This is that rheumatoid arthritis. It's just angry, it's inflamed, it's starting to erode a little bit. You're losing that support in those areas where you have that marginal erosion there. Here's some severe pictures of it. Right? What's going on here? Why does it look like that? This lady is severe. All of these are what? Dislocated or subluxed? Subluxed. They're touching. Subluxed. But what happened here is she's starting to get it in the pip joint of her 5th digit as well. And she's at a point to where she can't straighten her pinky. So the middle phalanx is actually straight up and down. That's a cross section of the middle phalanx. It goes right straight down. And she can't straighten it out because it's too painful and it's so severe. So that's just that cross section of that middle phalanx. So her finger basically has the proximal phalanx, the middle phalanx, and the distal phalanx. And that's what it looks like in real time. So this is your rheumatoid arthritis. Carpal metacarpal joints, you get that ulnar deviation. Okay, more commonly females than males. That's all kind of not that painful. And really they come in when they can't do their stuff anymore. Right? Hey, I used to golf, and now I can't golf anymore, or I crocheted, and now I can't really control the crochet needles, or whatever the case may be. I have a hard time picking up little things with dexterity because I don't have the full range of my joints. This is when they come in. They almost never come in when it's like this, because it's not that painful, so it doesn't bother them yet. They usually come in when there's functionality issues. It can happen in the spine as well. It is more common in the proximal joints of the hand. It can be osteoporosis, right? But primarily it can happen in the atlantoaxial subluxation area, like right in here. And it can cause that joint area to sublux. That's super extreme cases. I've never seen that, but it is a possibility, so we talk about it. Hands is what I need you to know for me. Because that's about 90% of these RA cases, you're going to notice it through the hands, not so much. It's fine, and then hopefully you get them off to a rheumatologist, so you got some DMARS or some other kinds of treatment for these autoimmune disorders. Questions on rheumatoid arthritis? Okay, so the difference between that and the erosive hypertrophic, carpal metacarpal joints, as opposed to dip and dip. No seagulls. This one has ulnar deviation of all those fingers as it gets extreme. Not very painful. Becomes painful in functional issues later on in life. Gout. Just talked about pseudo gout. Now here's the real gout. Big toe. More common in males than females. Doesn't mean females can't have it. Right? Increased incidence based on diet. Does anybody know what kind of diet? Good, remember it. Is that biochem or micro? Biochem? This morning? I didn't even know that. That's funny. Yeah, red meats, alcohol, the purine rich diets, right? Beans, those kinds of things. And how do we prevent this, which you're probably learning about, right? Change your diet. How many of those patients are actually going to change their diet? Yeah, because they're not going to do this. I've had a few that got sick and tired of dealing with it. They actually did change their diet and then completely eliminated their symptoms, and they were able to get off their medications. But it took some time for them to finally do it. But most commonly in the metatarsophalangeal joint, right? You can also have it in the elbow area. You get olecranon bursitis because of it. We'll see what that picture looks like in that area. Severe pain, right? Severe. That says on there the bed sheet, right? That's the most common complaint. They can't even put the bed sheet on. That's how much pain this causes when they have a flare-up. Okay? Inflammation, erythema, and the tophi on there. X-ray is still the study of choice. X-ray is still the study of choice. Here's what it can start to look like. Look at the swelling from the gout, primarily in that middle X-ray, right? With bad enough attacks and enough attacks, you start to get this erosion around the first metatarsal phalangeal joint. This one's so bad it's even going into the second one a little bit. More commonly in the first. Okay. We're going to be clear that gout, it's right there, bold and underlined. You do not need an X-ray to diagnose gout. Absolutely no need to. That is a clinical diagnosis. Don't need the X-ray to do it. Do not order X-rays on everybody who has gout. If you know it's gout and you're going to treat gout, just treat the gout. You don't need the X-ray. Now, if the gout attack resolves and you're still having pain in that area, now we're going to get the X-ray. How involved is it? Because sometimes this on the X-ray might be enough to make that patient actually change their diet when you show it to them. So look, you're starting to erode. This is going to be an issue down the road if we don't get on the ball here. The thing is like a rat bite appearance. Looks like a rat just kind of nibbled away at both sides there. Ratatouille got into town. Here's what the elbow and the ear look like on some of these patients, right? So if they get that olecranon bursitis, if you look at this X-ray, I will save you the time, but if you want to look at it as far as a normal elbow X-ray, it's a pretty good normal elbow X-ray. There is no bony abnormality on this film. But look at that. Look at that olecranon bursitis right there. That soft tissue. Tophi's over here in the ear. You see this a lot in gout patients too. Those are usually, they can be painful. Sometimes they're not painful. It just depends on kind of where they're at in their stage. But ultimately for you guys, for this, it's going to be the ear, right? Rat bite appearance, gout. You guys know the patient population from PATH. Okay. Questions on gout? Psoriatic arthritis. Okay, now what patient population? Well, anybody can have this one, right? Key things I want you to focus on with the psoriatic arthritis is a couple of things. One, we're still dealing with the small joints of the hand, but this one, especially the dip joints, right? So now we got one that really focuses, can it be other areas? Sure, medicine always can be. But we got ones that really focus on the dips, We got one that's dips and pips. We got one that's MCPs. We got one that's the MTP. So knowing the location will help you distinguish between these things. Okay? 25% of patients can develop skin manifestations. What are those skin manifestations? Anybody know? Psoriasis, silvery skin, right? Silvery, scaly skin. So if you have a patient that has that, this should be on your differential. Inflammation and pain in the affected joint, sausage fingers and toes. Sausage fingers and toes. Very, very common physical exam finding for psoriatic arthritis patients. What happens is the dip joints of the hands, the bones that make up the dip joints, primarily in the middle phalanx, start eroding. Right? It's one of those erosive arthritis. They start eroding. Okay? You typically don't see osteoporosis on these x-rays, but you get what's called that pencil in cup deformity. Pencil in a cup. So, some of these guys, I like this one better. Okay, so this one kind of talks about it because this is where it shows the bony proliferation where the tendons insert. So it's talking about where this is where the tendons are going, that's what's causing that. For me, this is your picture. This is your psoriatic arthritis. Right here. It looks like a pencil sitting in a cup. Sublux for sure. You see how it's eroding down into a point at the distal portion of those phalanxes. Pencil in a cup. Starts off a little bit, then we start to get the erosion starting, kind of muddles up the joint space here a little bit, and then all of a sudden we erode more and we get that pencil in a cup deformity. Can it happen in the hip joints? Yes, it can, but it's more commonly done in the hip joints. Especially if there's a patient that has a history of skin rashes or silvery scaled things, or they have sausage fingers. Yes, sausage fingers. No other way to describe it except to give you a picture. Okay. This is not very functional for these patients. Here's your pencil in a cup right here. See on the thumb? Kind of comes to that point right there. Alright, but if you got sausage fingers or short plump fingers or toes, psoriatic arthritis with the pencil and cup deformity. 25% of them have skin and nail changes too. So there's the skin changes and also pitting of the nails. Alright, that pitting psoriasis. Use your patient's symptoms as tools to help you have an idea of what you might be looking for. Promise you it will help significantly, especially when you get over there. Everything's symptom-based next semester. Everything. This is like a teaser. 1 second. Alright, one more. Ankylosing spondylitis. Strong association with HLA-B27, right? Remember that? I know you guys have heard that one before. No? Maybe some nods, some not nods, maybe, okay. Men more affected than women, usually between puberty and age 40. This is your low back pain, low back and SI joint pain, all right? X-rays your study of choice. What happens is the SI joints kind of fuse, and then you get something called a bamboo spine. When you look at the X-ray, it looks like a piece of bamboo, like when you went and saw the pandas at the San Diego Zoo. Right? The stuff that they eat. All this stuff is just more information about ankylosing spondylitis. That's FYI. This part that says FYI only is FYI. This part is not. So there's a big red line. Okay? Stuff on the right, it's more information about ankylosing spondylitis. Stuff on the left is how you distinguish it and see the bamboo spine. So, primarily, I want you to look at the first picture on the left, and we saw some before with our vertebrae, right, in our joint space, but you see how it almost looks like the spine is one big bone here, one big piece of bamboo. I have almost what looks like cortex on the anterior portion of that disc space, connecting all the vertebrae together. In extreme cases, it would do it on the back side as well. This is your bamboo spine. ossification of the outer fibers of the discs. It also, this is normal. Isn't that pretty SI joints here? I know we haven't gotten into the pelvis too much yet, but those are pretty SI joints. They're not there. They have fused together. They're supposed to look like this. I get that there's bowel and air gas here. This one's actually better to see that it's all kind of fused together. So it's a white line now instead of a black line. Synthesis is fused together. I should have a nice kind of joint area right there where those two came together. It's all fused. This is really the one. If I give it to you, I'm going to give it to you as a lumbar spine. I'm not going to give you a pelvis for that one. Okay? Bamboo spine. It ends up fusing this. Becomes painful. Back arthritis, right? It hurts to kind of bend forward because they don't have that flexibility anymore. It's calcified. There is no flexibility. They can't do all of this. Questions on ankylosing spondylitis? We'll stop there for today. We'll go into infectious tomorrow. Okay? I will stand up here. Please ask your questions. I know it's thick, kind of go through all this stuff. A little bit quick, but that's kind of trying to just break down how you can pick these things out, right? How do I pick it out? So that way you understand how you can pick it out, especially at your level without seeing any patients yet. So look at those things. If you have any questions, let me know.